Hello, good day. My name is Mindy Frost, and I'm a technical officer for the World Health Organization within the Risk Communication and Community Engagement activity, which is under the Infodemics Management pillar of the COVID response here at WHO. Welcome to today's program called Capturing Hearts and Minds with Facts and Figures. Where is the evidence for community engagement? So we're going to learn more about that from our presenters today. Today's program is a joint initiative from the World Health Organization, Infodemics Management, and the Global Collective Service. The Collective Service is a fairly new initiative between WHO, International Federation of the Red Cross, UNICEF, and with support from the Global Outbreak Alert and Response Network. Today's program is really going to focus on a really interesting and important topic. While community engagement is now more accepted as ever as an important component, critical component of outbreak responses, the art and science of it vary greatly in practice. And there's often a general lack of rigorous monitoring and evaluation. And today, we'll talk about a review of evidence base from community engagement approaches and models used in past epidemics, like the recent Ebola outbreaks. These will be presented along with insights from the implementers on how these contexts and what the lessons learned can be attributed and used in the COVID-19 response. So with that, I'd like to introduce today's presenters. We have Amaya Gillespie, who is the coordinator for the Interagency Working Group in the Middle East region for the World Health Organization. Next, we'll hear from Jamie Benson, who's the lead author, and he's currently a consultant with the Bill and Melinda Gates Foundation. And he's the lead author on one of the papers that we're going to hear about from an evidence base from the Ebola outbreak. Next, we'll hear from Mohammed Jello, who is the CEO of Focus 1000, which is an NGO based in Sierra Leone, and it focuses on data collection. He was also a co-author of the paper that we'll hear about. After that, we'll hear from Nadir Al-Ganja, who's a project officer for the International Federation of Red Cross in the Libya country office. And then finally, we will hear from Samara Alfeki, who's a regional officer for community engagement and the lead for community engagement under the RCCE pillar for the World Health Organization. So at the beginning of our program, what we'd like to do is hear from you. So we're going to start off today with a couple polling questions just to better understand who is out there listening. So with that, why don't we get going with our first polling question? Okay, so for our first question, very simply, are you currently doing community engagement work in some way? Yes, no, or you're not exactly sure. And if you just click on your screen, then we can get your response there. Okay, I think it looks like the vast majority of participants today have been using community engagement in their work. So that's great. Okay, why don't we go on to the second question? Great. So the response there is overwhelmingly yes. Okay, and so for a second question, have you previously worked in community engagement in the past prior to COVID? Okay, again, it looks like an overwhelming yes. So it sounds like we have a fairly experienced group of people that we're working with today. Okay, and then we'll go to our third and last question. Okay, do you have experience working on community engagement at scale? So a large project around community engagement. Someone's looking a little closer. Okay. For here, it's looking a little more leaning towards no, and kind of what we had anticipated, that many people have experience doing community engagement work, but maybe on smaller individualized studies and projects. So it'll be really good to hear about more evidence base that we can be applying to our programs now that you're working on in community engagement. So before we begin with our first presenter, I just want to let you know that while there is a chat function as part of Zoom, any questions you have for any of the presenters, we have 2 question and answer periods throughout the program today. Please put those questions in the Q&A function, and that's what we'll be looking for questions to ask the presenters. Also, we have live interpretation, so if you need that, it's in French. You also see that on the bottom of your screen as well. So with that, I'd like to introduce my colleague, Amaya Gillespie. Amaya?
Great. Hello, everyone. And I believe some slides will come up onto the screen very soon. Thanks for joining, everybody. Today's topic, we really want to talk about the challenges around collecting evidence for community engagement. The reason that we launched straight into the challenges is because there really isn't so much out there that's published. And so today we have the benefit of having a couple of the authors from some of the most recent papers that look at the impact of community engagement, both from learning from the Ebola epidemic just a couple of years ago, and also thinking about what the translation of that experience is into COVID, and also some very recent articles that I believe have already been shared with you. So next slide. So we're not talking so much about the actual process of how to, and that's kind of good because this audience is actually quite skilled by the sounds of it, with quite a lot of experience. But I guess we've already identified one of the big challenges around community engagement, and that is that it is not often done at scale. You know, we do small stuff and we see impacts from it. It's often not connected to the bigger picture, to decision making, etc. So, in fact, one of the articles that we'll talk about today, the experience from Sierra Leone, what's brilliant about what they've done is actually published a very large scale project. Took a little while to get it out there. It was hard work, but that's also why we're bringing people together to see what the impact of community engagement can be, so that we can justify the work, but also to understand a little bit about how that was done. Now, we do have evidence from a whole range of issues in public health, you know, everything like going back to HIV in particular, in the early days of HIV. I feel like that was a time when community engagement and participatory methods really came into their own as they became sort of integrated into just about everything we did. But even though there were a few very well-funded, really good studies, particularly in Southern Africa on that and parts of Asia, many times the evaluation wasn't as solid as we really need it to be and as we see it in other areas. But we do have evidence from a whole range of issues for the benefits of community engagement, for improving the quality of services, including for improving client satisfaction in services, for definitely the responsiveness of health systems and strengthening it, and basically that buy-in. And again, thinking about HIV, where that term was coined, nothing about us without us, and we now hear that used in a whole range of other issues as well. So we see the benefits of community engagement at different stages in projects, and of course most of us would suggest that it's a part of all stages, but everything from designing the intervention, like from the very beginning, conceptualization, definitely in building trust. Community entry is a very important component, perhaps a little understudied. And definitely we're hearing a lot more about risk communication with the onset of COVID-19, and of course the core social and behaviour change component, which is really the point of a lot of the community engagement that we're doing. then I just make mention of, particularly in the context of COVID-19, that there's also the opportunity to integrate community engagement into what we call the supply side, so the service side of like surveillance, contact tracing, logistics, administrative support. And it's actually not often done either, that integration. And again, we'll hear a little bit about that. Next slide. So just to frame for a second what we mean by community engagement, I think many times we're working perhaps on the left side of this continuum around informing and consulting with people, you know, the public, people from communities geographically or thematically linked. We involve them, we even collaborate. But this whole issue of empowering people is really a much bigger question. And what is that? How do you measure that? These are really the big challenges when we start talking about what is the impact of community engagement. And I appreciate that these might not be everybody's favourite words for describing community engagement, but there's definitely a continuum, whichever are your favourite terms for that. Another challenge we have in public health, of course. Next slide. So just to outline a couple of the points that you'll be hearing about in terms of what is difficult about this. Firstly, the definitions vary, not only the definition of community engagement, you might know it when you see it, but it is hard to explain what it is, but also the definitions of evidence. Very often we only respect quantitative evidence, when in fact it's hard to make sense of quantitative, the numbers, unless you also have the qualitative. So it's very important when we're talking about data and evidence that, it's understood that we're talking about qualitative and quantitative, and particularly the role of community in gathering and interpreting that. Then the whole idea of attribution is very difficult. Because COVID went up, went down, and there was community engagement involved. Do we know that that was the key thing, or was it just one of the things? Very hard to petition out impacts like that as well. It's also very much a process, not a destination, meaning that, it is difficult to know how much is enough. Would a little bit more be better? The whole dose response idea. Very difficult to pin down what is success when there's a process involved. Often observation is important, and categorizing data, and of course that's when you can get variability as well. Related to that, it's very much a feeling, not necessarily a fact. People may experience it very differently, good community engagement versus something that maybe didn't feel so good. I think also it's tremendously labour intensive, and often we don't really stay long enough working with communities, and certainly this challenge of scale as well is really quite a big issue. So I think there are a couple of other slides that you'll receive these slides as well, I believe. There's a couple of other slides that are taken from the most recent studies that we've seen on the impact of community engagement on COVID-19, and also the one you're going to hear about around Ebola. So there are a couple of extra slides that clip out some of the sort of key points as well for you to consider later. But with that, I would like to go to Jamie Benson, who is the lead author on one of these articles that we want to dig into a little deeper. And this is about the experience of community engagement and Ebola in Sierra Leone. And it really is at quite large scale. So thanks very much for joining us in the very early morning, Jamie. Over to you.
Thanks, Amaya. And hi, everyone. Thanks for the opportunity. Greetings from a very cold and very dark Seattle, very early in the morning. I've got a lot to get through right now, so I've tried to put together some slides that give a lot of background content, so I will skip forward quite quickly but that will be available for everyone. The key objectives today are, along the lines of what Maya was just talking about. I'm going to describe this initiative in Sierra Leone. We need to provide some context for the data and evidence that was collected, because when we're talking at scale, this was in 12,000 communities, approximately 50 to 60,000 community visits. So it was considerably large. Talk about some of the key components of that, the data that was collected, how it's being used, and then hand over to a colleague who's going to talk about how this is kind of carried on during COVID. But one of the key elements underpinning what we're going to talk about now is that data can be collected at national level, quantitative and qualitative at scale by community members. Next slide. Before I go ahead, I just want to put up the faces of the people responsible for this. Everyone here was either responsible for design or implementation or government coordination, actually doing the mobilization at the front lines. We have chiefs here, but I just want to make it very clear that this is presenting the work of the people focused here, and it's not without the incredible efforts of the people here that we wouldn't have this data if they hadn't put the efforts in. Next slide. So the Social Mobilization Action Consortium was a government-led community engagement initiative, and it included the 5 organizations here. I worked for Restless Development at the time. My colleague Mohammed worked for Focus 1000, and the idea was to have a multi-platform RCC approach. So it was a range of organizations doing messaging, face-to-face mobilization, and mobilization of religious leaders. And we have numbers here. It was large scale, 2,500 mobilizers, 6,000 religious leaders, and all radio stations in the country. We worked across 70% of communities. And I'm going to focus mainly on the element that was community-led Ebola action, which was a participatory community planning approach drawn from HIV/AIDS and CLTS. Next slide. I won't go through all of this in detail, but the philosophy of the SMAC initiative was both demand and supply side. And Amaya was just talking about supply side a little bit. So demand was to accelerate behaviors and actions that will reduce transmission. So individual and collective actions at community level. And then supply side, essential was the integration of the evidence and the data that we were finding to help other pillars, surveillance, case management, etc., to improve their service based on the community feedback that we received. And remembering that in the case of Ebola, burial teams were in the middle of communities actively working all the time. And so there was a real opportunity for real-time adjustment. Next slide. So I'm going to organize, just quickly give some background on the program by the core elements and why, I don't want to focus on the how-to too much. But without having some of this background, it's difficult to estimate how much data was collected and how that was achieved. Just in terms of quality, there's 2 elements. Having a participatory planning, so we're not talking about participation for a community meeting to inform. This was to create action planning using participatory approaches, PRA tools, and they're listed here and they're described in the paper that Amaya referred to. And there's also a handbook that was used that I'll share at the end of the presentation. Making sure that we had operationalization at large scale. So there was a systematic feedback mechanism, and this wasn't just community meetings again. Every community was provided a SIM card with a phone number that went straight to the response center. The response center was manned by SMAC community engagement officers. And so essentially there was a communication mechanism of 12,000 communities, 200 staff that was linked directly into the response mechanism. And so we will see that we weren't just collecting data via that mechanism, then it became a surveillance mechanism, it became an alerts mechanism. And then a part of that quality was revitalizing religious groups that Mohammed will talk about shortly. Next slide. Coordination and integration are the elements that are often left out. So to ensure that the data and evidence collected was injected straight into the response, coordination was essential. And so as part of the project, there was a secretariat established to directly liaise with the Ebola operation centers. Government leadership is key. In the end, this is a government program, and so we put resources towards supporting capacity building of very small departments, the health education department that would never normally get resources. And that's one of the reasons that community engagement doesn't have the kind of attention that it should receive, because the departments are very low resource that are working on these issues. So alerts desk maintenance, there's approximately 4,500 alerts called in from the community mobilizers, noting that this is not the surveillance pillar, this was community engagement. But if you're in communities once every 2 weeks or once every 3 weeks, and you've provided mobile phone mechanisms for people to be contacted, it ends up resulting in some kind of alerts that then you can collect data on that. There was a weekly sit rep on community engagement, just focusing on community engagement. And then there was support with the development of SOPs, which I'll allude to in a minute. Next slide. And then finally, just resource mobilization. Key to this is the frontline workers, training mobilizers, training them for a week, regular follow-ups, payment for the work undertaken, codes of conduct, insurance, making sure that community engagement officers were treated almost as if staff, because one of the key issues with community engagement is the expectation that people will do work for free for their communities. In an emergency response, that's just not good enough. Next slide. So just quickly, just a very quick overview. Pairs of mobilizers were recruited, one male, one female predominantly. One of them was a former volunteer for restless development. The other person was usually nominated by a community. The mobilizers came directly from those communities, spoke the same language, obviously, and came from at least nearby in the chiefdom. Because of the nature of community engagement, nature of the Ebola outbreak, risk of placing people in communities was high. And so there was an effort to centralize mobilizers so they can move around. Next slide. And I'm just pulling out, I'm going to provide the training materials for everyone that was used in SMAC, but I'll just quickly give an overview of a couple of the slides. As you can see here, there was a rotation process. So community engagement officers went to Village 1 on the first day, Village 2 on the second day, Village 3. They did a triggering exercise, which was to elicit action from the communities and the development of action plans. And then they would follow up with those communities in rotation for a year. And so some communities received 5, 6, 7, 8, 9 visits, and they were in constant phone contact with the either community mobilizer or the field officer responsible for that region. Next slide. And there was a weekly schedule. So mobilizers did mobilization 4 days a week. Every Monday, they came together and bought their data, the hard copies of the data, to be consolidated and sent to Freetown for analysis. And so we were capturing many surveys on a weekly basis, thousands, and the paper that we published has a chart demonstrating how many community visits there were on a weekly basis. But if you say 1,500 mobilizer pairs visiting one community every day for a period of a year, we get fairly decent amount of surveys. Next slide. And this is just the last slide from the training, and it kind of underpins why this methodology was utilized. It gave the opportunity for mobilizers not just to go to door and give messages, but to spend 5 or 6 hours with communities creating action plans and then helping with those implementation, connecting community members to resources they needed to implement those community action plans, updating them, understanding what the challenges were with implementing them. Having this process meant that there was safety and security for interns and staff. We knew where mobilizers were any hour of the day, and we were able to call them. We can then make sure that there's consistency of messaging. Every week we're collecting data. Every week the mobilizers are coming together. They're getting the information on the new data that's been analyzed, and they're taking that out again. So it was a true feedback loop that was actually being reinforced on a weekly basis. Next slide. So what data was collected? We established this system. All of this was done very quickly in an emergency situation. But again, what I want to stress is that with some preparation and planning, a large amount of qualitative and quantitative data can be collected, and all of it is valuable. There is a leaning towards qualitative data, which is essential, but quantitative data in an emergency can teach us a lot. So the scale data we collected is micro mapping of community champions and leadership contacts. So we had a number for at least one person in each community, and we're able to map that And so that's approximately 12,000 contacts that we were able to then maintain and be able to keep track of what was happening in those communities. We have data on the location and date of each community visit, the estimate of those who attended, and we now know there was about 5 million face-to-face interactions, which are often repeat interactions. So that's a cumulative number. We received self-reported community health data, so deaths, burials, referrals. Survivors, we asked about whether survivors were living in the community and what their experience was. Very important was the action plan. So we know which of those 12,000 communities had action plans, which is essentially all of them. But then the issue was how much progress are they making against them? We logged specific action points. We have about 63,000 of those. And the action points were things like, we're going to do safe and dignified burials. We have a bylaw around that. We're going to make sure that we don't have huge amounts of people coming in and out of the community. But action points could also be associated with, we commit to provide transport for those that need to go and get medical treatment. Or we commit to cleaning up our environment, so to make sure that we have a good sense of how the community is responding to this as a community. So key was to not just focus on the disease itself, because as we know, in a situation where there's relatively low transmission, just like we see with COVID now, where we have high rates of transmission everywhere, but people might not be experiencing it in real time, but the socioeconomic impacts, the health access impacts, all of these things need to be addressed. We got captured community concerns and ideas. Yes, rumors is important, but eventually you kind of have a sense of what the key rumors are. But what we want to know is, what are the concerns about the response that people need to address? And also, what ideas do they have? How are these positive actions helping keep communities safe? If we have data on community actions in large numbers of communities with low or no transmission, maybe we can take those ideas and turn them into programmatic interventions. And the SITREP included a combination of those, and I'll give everyone a link to the SITREP so you can see them. One of the challenges, unfortunately, is we only had very poor community engagement indicators in the overall SITREPs that were coming from the response, and they were, community resistance, which doesn't really tell us anything about community engagement. So we had a standalone SITREP for community engagement that I'd love to see replicated elsewhere. Next slide. So why collect all this data? In retrospect, we probably wouldn't collect so much data again in an emergency, but this was a unique situation where there was a lot of resources put towards community engagement in Sierra Leone. But there's two elements to the data, and I'll talk about both. In real time, collecting quantitative data on where you're doing community engagement and how often helps with resource allocation and coordination with other partners. Micro mapping to know there's 10 mobilizers working in this district, to be able to map that against other organizations was incredibly helpful. And that was how we designed the standard operating procedures for Sierra Leone. And I'll talk to that in a little bit. Community surveillance. In real time, if you have established this community engagement mechanism, we found that we were able to do a lot of calling in of alerts. And actually in some districts, the mobilizers under this initiative were calling in more alerts than the surveillance officers. To have a database of obviously messaging and knowledge, attitudes and practices, and being able to keep track of those and develop messaging. And then the SOP development, because we were collecting data on burials, on case management, on treatment centers, what we're able to do then is take that information, and over a process, in early 2015, standard operating procedures for all the pillars were developed out of the information that came from us and others, all government database. This was essential, and that SOP process is also documented in a paper, so there's evidence for how that worked, and the SOPs are available. Without the SOPs at pillar level, we have a disconnect between what community engagement is doing and integrating that into the other pillars. And then the next element of that, and this is something that we're working on now, is the retrospective use of that data. So the Bill and Melinda Gates Foundation has a project that's been running for about 4 years. And that's looking at how do we provide evidence for the impact of community engagement. And Amaya was saying it's very hard to attribution is an issue. the issue of demonstrate how other interventions, there was lockdowns, there was different kinds of things that happened, treatment centers opening and closing. Of course, all of that had an impact. But what we're trying to do is look at longitudinal community engagement, which is what we have data for now, and then putting that together with the EPI data, the Sierra Leone Ebola database, which is held by the government of Sierra Leone, to look at if there is a correlation between the dosage of community engagement. So if communities that got 2 visits versus communities that got 6 visits, do we see an impact in transmission? Because one of the theories of SMAC was that repeat visits from the same trusted people would have a higher impact. What we've also been able to do is code qualitative data. And we have an article published in Lancet earlier this year that looks at the impact of unmet needs not being met on behavior. So this is a real lesson for us as we implement that we tend to just go for the disease itself. Messaging around COVID, messaging around Ebola. However, in the real lives of the people that we're working with, it's the socioeconomic impacts, it's the other health impacts, it's impacts related to education. We saw teenage pregnancy, marriage, all of these things. Often there's not data collected in the context of the outbreak, or there certainly wasn't during Ebola in Sierra Leone. So being able to look at that and say, we found that unmet needs being met, so issues like safety, issues like trust, if they were met, then there's more likely to be adapting of the positive behaviors. And then finally, we can do cost-benefit analysis. How much do we spend for mobilizers versus how much reduction in transmission, and then operational analysis for future interventions. Next slide. I've got 2 more slides to go very quickly. There's some of the key components. CAP surveys at the start and ongoing so that we can measure progress, standardization of technical and operational approaches, and then UNICEF's recently published minimum standards for community engagement. It drew to a large degree on the experience in Sierra Leone and SMAC, and so I recommend everyone have a look at that. Make sure there's a clear participatory approach, integration with government, pillars are, SOPs are essential to make sure cross-pillar works. Coordination, shared indicators, and a neutral coordination mechanism, which we're still struggling with. Micro mapping and investment in time and data collection, it's just essential. Often that's the thing that's not funded for community engagement. We need to collect that data in real time. Next slide. And then finally, here's just a resource page. These are we're starting to have some evidence come about. The first 2 papers are directly drawn from this initiative. The SOPs were developed in conjunction with the government of Sierra Leone. Mohammed will talk about the CAP studies. We're about to release a paper on the digital data collection that was undertaken. About half the data was collected using mobile phones, which is a whole other experience. And then I've got some links here. I'll put a Google Drive up with all the relevant materials. They're free for everyone to use. So I'll wrap up there. Next slide is my last slide and favorite slide. This is Florence Bengali. She was a survivor, directly linked into our program, and it reminds us why we're doing the work that we did. A real focus on just ending disease transmission. And I'll leave it there. Thank you.
Great. Thank you, Jamie. What a beautiful slide to end on. Yeah. Gorgeous. Thank you for sharing that. Yeah, really fascinating. It's perfect timing, I think, for us to really learn from the bolus that you've done, and a lot of it that you've done with Mohammed, who's our next presenter. So Mohammed's going to shift over and talk a bit about the work that you 2 did together and his work through Focus 1000, but also touch on some of the finer points with work with religious leaders and how the lessons learned have been able to be adapted and used during the COVID-19 response. So thank you, Jamie. I remind all of the participants, if you have some questions for either Amaya, Jamie, or Mohammed, please go ahead and put them in the Q&A function at the bottom of your screen, and we'll go to those questions just after Mohammed's presentation. Mohammed?
Yeah, well, thank you so much, for this opportunity. Nice to be here. Yeah, and giving us this opportunity. Like you said, Focus 1000 is a national NGO, and we work in the area of health, basically, trying to see how we can support governments to work on, improving the health outcome of women and children. But then during the Ebola, crisis, we are part of the consortium, the SMAC consortium, and we focused, on working with religious leaders and traditional healers to, support community engagement activities. We were able to draw back from our experience, during the Universal Child Immunization Days in the 1980s, where, Sierra Leone was able to achieve 75%, immunization coverage by 1990 from a very low base of 6%. And, religious and traditional healers made a significant, contribution to that. We're also, involved with the NIDs from 1993 to 2000. And that's also made, significant impact. Then, of course, the Ebola epidemic, and presently, using the experience from that to support, the response to COVID-19. Next slide, please. Next, please. Yeah, so the religious leaders, the experience we had with them, we now decided to bring in other key actors in the community. We had a total of 6,000 religious leaders that we were working with. I don't know, we need to go back, if you don't mind. Hello? Hello, can we just go back here, please? So I was saying we have 6,000 religious leaders, then of course the chiefs. But what we decided to do now later was to bring in traditional healers. So we now have about 10,000 traditional healers, youth representatives, the media and civil society. We have them from national level, district, chiefdom, and the section levels. So we have all these are mapped out. We know their names, the mosques and churches where they work, and their communities. Next slide, please. Yeah, so we tried to get the evidence, and we were able to, for programming. And believe me, the scriptures, the Bible and the Quran provided, very good, supporting messages, because we wanted to give the context. Most people during the Ebola, we are saying, they continue to wash dead bodies because it is part of their faith. They have to make sure that that is the last respect, to their loved ones. They were also, refusing to, accept quarantine, and of course the issue of hand washing. But then, we got the religious leaders to go to the Bible and the Quran, and they were able to quote relevant verses from the Bible and Quran that supported hand washing. Verses that supported, the issue of not washing dead bodies, because they even gave example of the prophet, where he buried, his disciples and relatives without washing them. So the question was, it's the Quran that says, or it's the Bible that says we need to wash dead bodies. But then the argument now was, okay, look, that is during normal situations. But then the same Bible and Quran also says, in situations that are not normal, you are not expected, to wash dead bodies, especially if that becomes, a route of transmission. So the same thing we are also now using for COVID-19. The issue of handshake, it's part of our tradition. But the Bible and the Quran, we have relevant verses, quoted, to show that you don't necessarily need to, shake hands, or, to hug, because you don't want, to transmit infection. So those were the evidences that we are using to support the public health messages. Next one, please. Yeah, so what we are doing, in fact, we're able to use images, images of the religious leaders, because we believe that the messages are good, the materials are good, but usually, we forget about the messenger. So we put so much emphasis on the messenger because we believe that the messenger is as important as the message. So we got these respected leaders to go out, and have messages from the Bible and the Quran, then messages on development, pre-testing and finalization with the community, They use these messages in their sermons, and they developed, IEC materials, which were distributed in mosques and churches. In fact, it was so interesting because there are times when in the mosque, they wouldn't allow you to put any posters. But then some of these posters, because they had images of the respected leaders, or they had, inscription from the Bible or the Quran, these institutions allowed us, to even post posters, in the mosque and churches. Public education through mosque and churches, and the mass media, we got religious leaders on television, religious leaders on radio. So because we found out that radio was the widest, channel of communication. So what we did now was to combine, when you have the religious leaders on radio, it had, a synergistic impact. Home visits, community dialogues, undertaken by the religious leaders. And we also facilitated research and studies. The information we got from both qualitative and quantitative studies, we fed back into the communities. For example, during one of our study, an old lady said to us, when you tell us that if we go to the hospital or the health centers, there is no cure for Ebola. So, but why do you think we should go? But when we go to traditional healers, they tell us that they can cure. So we took that information back to the national, the decision makers, and we are now able to use that to revise the messages that, instead of saying there is no cure for Ebola, we revise it to say, if you went early to the health facility, there are more chances for you to be cured. So that's how we use most of the messages from the studies that were being used. Next slide, please. Yeah, so the scope, we use the information, you will see images of our religious leaders, even now with COVID, promoting the use of face mask, because that is one area also where we have been having resistance. So we have our religious leaders to go out, have, sessions to build capacity of community stakeholders, and use the example of modeling, where you have the imam and the pastor going out using the face mask. That has added a lot of value, with our COVID, response. Like I said, we also put religious leaders on the radio and television, for public education. And also, we've developed, key booklets where we've been able to look at, messages from both the Bible and the Quran to support the public health messages. And I think this is going out very, very well, because now people are seeing that you are not only talking, but then you are getting evidence, from the same scriptures which they believe. And I think this is making a big impact, but the emphasis though is to see how we can give more priority to community engagement instead of just lip service. That is why I'm so happy that we are taking this move, to get evidence to support whatever we are doing in community engagement. Because usually it's like I usually use the example of the vehicle, that people think social mobilization or community engagement is only a spare tire. You only need it when you have a puncture. But what we are saying is that community engagement should be part of the 4 tires. It's not only when you have a puncture. It should be part of the 4 tires, if not the steering wheel. Thank you very much. If you have any questions, we'll be ready to answer them.
Great, thank you so much, Mohammed. So with that, we'll move on to our question and answer session. I think a number of people have been putting questions into the Q&A function, so we have a couple to start off with here. The first one has to deal with accountability. I'll just try to get that one up here. So do you use messaging and your surveys for accountability purposes? So what was your experience basically with the compliance mechanisms? So I think that probably goes to Jamie.
In terms of accountability, it was a fundamental principle of the program that if we were going to collect data constantly in real time, that would we committed for that to go back to communities and also to go to government. And so we don't have evidence to the degree that there was accountability for the program. But what we do know is that the information that was generated on a weekly basis, within 12 to 15 days, that went back to the communities in some form, whether new messages or answering questions. And then in turn, we were able to go back and check whether government had implemented what they'd promised to implement based on the data that we collected. So there was a built-in accountability mechanism there. The broader issue of accountability, whether we should have had a large-scale program that was implemented, in every community very rapidly, I think there's more work to be done around how, with a bit of preparation, we probably would have been able to do that with more responsibility, because essentially if you go everywhere at once, there's issues of standing on other people's toes, of undermining initiatives that are already happening in those communities, and that's something to be really conscious of.
Okay. That probably links well to the next question, which is, it may be a bit sensitive, but I think there's a question out there. Generally, how was it to maybe manage a group of people in a community that you quite obviously weren't part of? So I think the dynamics of coming in as an outsider running a program that has primarily with trust in the community, and then managing individuals, I think that they were probably from the community. Just what were those dynamics? How were you, I assume, able to build trust? Were there any issues around that?
Yeah, well, the bottom line is I didn't do community engagement. That wasn't my responsibility. My responsibility was to be a facilitator for the organization that I worked for. And I worked with a team of professionals within an NGO who came from Sierra Leone. So the trust was built. I was working in Sierra Leone for a couple of years before Ebola came, so it wasn't flying in to work just on this issue. But part of it was, if you have an organization where you're working with a strong team of professionals and their capacity is being built, that trust is built internally as an institution. Then when it came to the community engagement, no, I never visited a community other than my own community in Sierra Leone during that period, because that wasn't my role to do that. Community engagement should be done by the people who live close to the communities or are part of those communities. And the best, in real time, the best information you can get are from team members on your own team who come from those communities themselves, and you have to trust in them. So the trust was going the other way, that I had complete faith in those that were doing the work. And my job was to just help facilitate, get money, and make sure that the structures were in place for the team to do the work that they were doing.
Okay, great. Thank you. We have another question from Kim Hartog, who I think the question should be for Mohammed. Generally, what was your experience regarding potential stigmatization? She was wondering specifically around the religious messages and for behavior change, and if any of this potentially triggered any type of stigma issues in the communities that you worked in.
Yeah, exactly. One of the key areas, that we had to address was stigma and discrimination, because especially during Ebola, there was a lot of stigma, against health workers. People were thinking that the health workers were responsible for transmission of the disease. Then also, the Ebola survivors, people were scared. In fact, people, house owners, evicted anyone who was, a survivor. So it was a major issue. But then now we got the religious leaders to go back and use the scriptures, to say, we are all human beings. Why do we discriminate against somebody just because the person is infected? And because the message was coming from the religious leaders themselves. The religious leaders were also, hugging some of the survivors to show that once they were, free, they were no longer transmitting the infection. So we use the religious leaders as role model, and that's made a big difference. So again, talking about trust, that is why we believe that the messenger is equally, if not more important than the message, and for us, that was one of our key principles.
Okay, great. Thank you. We have another question, actually one I'm quite curious about as well. And that's, so how do you find that communities are reacting now to COVID-19 and the pandemic compared to how they reacted during the Ebola outbreaks? Do you find that they're more resilient or resistant, or generally what's your take on that?
Yeah, I think especially in Sierra Leone, where we had this, huge outbreak of Ebola. And, during Ebola, there was a lot of resistance, especially at the beginning. There were a lot of rumors, linked to political entities and all that type of stuff. And so when we now had, COVID-19, we still had the issues of rumors. But it was not too difficult, for us to address, because we used the experience of Ebola to tell them, say, look, this was how we started all these rumors, with Ebola, and look at the consequences. So many people got infected. So many people died. So now why don't we look at the science? Why don't we believe our religious leaders and our traditional healers and our health workers? Why don't we believe in them? Because, from experience, with Ebola, we found out eventually that it was not the health workers who were transmitting the infection, but really they were there to help us. So using that platform, the experience from Ebola really helped. And now people, we are more aware. There was now, it was less resistance, and people were a bit more cooperative. And because also we had the structures in place, we already had strengthened some of the community structures, the chiefs, the women groups, the youth organizations, the ministry itself. So I think it was a plus, using, the experience from Ebola. Although, I cannot say there was no resistance, but it was not as much as during the Ebola crisis.
Okay, well, I guess that's the Ebola crisis, and that you were able to take what worked and was already well practiced and in place, and then applied it, unfortunately, to the next emergency. So, okay, thank you. Thank you, Mohammed. Thanks for sharing that. Your lessons learned, really valuable. And that'll be nice to see this area grow in terms of evidence base for community engagement practices. So thank you. So with that, we're going to go on to our next presenter, Nader Al-Ganja, who is the project officer for International Federation of the Red Cross in the Libya country office. He's going to share with us his experience on volunteers in every street in Libya. So another at-scale program that we can learn from. Nader?
Yes, thank you, Mindy. So I will be talking about the initiative of the Libyan Red Crescent, which is volunteer in every street. Next slide, please. So as you know, in the beginning of the COVID-19 outbreak, risks were considered very high for Libya. That's due to the complex emergency in the countries, the conflict, the fragile health system, the weak disease surveillance mechanism, and the overwhelmed response capacities. All those factors made the impact of COVID-19 on the vulnerable population and group in Libya very high. Those include the migrant, the IDPs, the refugees that already suffered from poor access to information and to health services in the country. At the same time, there was an overload of information about COVID-19 that included rumors and false information that was being circulated in Libya through the traditional and through the social media ways, which caused panic among the population and really increased the risk of adapting an effective prevention measures. Next slide, please. So Libyan Red Crescent is actually the main national humanitarian organization in the country. The country is divided, and the Libyan Red Crescent is the only humanitarian organization that have access to the entire Libyan ground. The main services that are provided by Libyan Red Crescent are focused around health. With their community-based health team, they run primary health care centers, mobile clinics, provide mental health and PSS, psychosocial support to vulnerable groups, and also deploy medical convoys to areas where the health facilities cannot provide the basic needs. And also provide the first aid services to individual and during emergency. Next slide, please. So in Benghazi branch, Benghazi is the second biggest city in Libya. The community health volunteer started the awareness activities within their communities at the beginning of outbreak. However, at a later stage, when the movement restriction took place, those volunteers couldn't access many areas of Benghazi, and therefore there was a need to modify the approach, and the branch decided to launch the initiative, which we are talking about today, which is Volunteer in Every Street. So the idea of the approach is to literally engage and recruit the local community member to provide the health awareness in their own surrounding and in their own neighbors. Next slide, please. So the process of this initiative have 8 main points. So the first point was development of volunteer guide. This guide really had all the information that were provided through the IFRC and WHO and NCDC in Libya. All information about the virus include the basic information, safety precautions, the role of volunteers, and advice about how to communicate with the community. Everything was made in the simple language that everyone can understand and everyone know how to follow it. The second step was development of a survey to better understand the need of the community. So this survey was developed with the support of IFRC, and later was shared on social media, where they asked the people to answer some simple question, and based on the result of this survey, a guide was developed for frequently asked questions. This guide really helped the volunteer later when they worked with the population. The fourth step was launching a campaign on social media. This campaign was to explain the initiative for everyone through simple video, and also to invite the interested community members to join. The fifth one was to run a training for those members that wanted to take part in this initiative. They were trained on all COVID related topics that they will need in this initiative. And then there was assessment test that took place, and about 220 volunteers succeeded in this test. So in order to be deployed on the field or to be engaged and take part in this initiative, you need to pass this assessment that consists of answering at least 18 right questions out of 20. The sixth point was organizing the team on the field. So later I will show you the map. So the teams were composed of team leaders and volunteers from that neighborhood. And at the beginning, there was not a clear map about the distribution of the volunteers in Benghazi and how it will be like. So what the team did is they asked the community to define their own neighborhood, how they believe those neighborhoods are located, where they start, where they finish. And according to that, a map was developed. If you can move to the next slide, please. Yes, so this map was developed by the volunteers. It's included 32 neighborhoods within Benghazi, according to the people who are living there and according to the information that was collected. And each of those neighbors were later covered by a team of Libyan Red Crescent volunteer. Can we go back to the previous one, please? Yes. So the seventh point was implementing phase. So team, as I mentioned, had at least one team leader and the volunteers from that neighborhood, and they worked door to door, always keeping in mind to keep distance and to follow the precautions related to COVID-19. And of course, there was a continuous monitoring. There were field visits and also forms that the team leader had to fill every day concerning how many visits have been achieved. And also the locations to assure that the coverage will cover all the neighborhood. Can we move to the next slide? Yes, so those, as I showed, are the areas that were covered by the volunteers. Next slide, please. So yeah, what the community volunteer have found there, that some community member did not welcome the visit at first. Some people didn't really understand what they are trying to do, but the volunteers being themselves from those communities and taking the time to explain the goal and everything and their role really helped to change the mind of the community, and they started to accept them more easily. The volunteer used a simplified local language dialect to stress on the importance of taking preventive measures. At that time, there were a lot of wrong information in Libya. Some people thought that Libyans had took vaccination that already took vaccination that prevent them from getting COVID-19. Some believe that since Libya is relatively warmer than other places, virus wouldn't survive there. So they didn't want to follow those measures. So volunteering played an important role to make the local community follow those measures, wearing masks, practicing hand washing, and keeping physical distancing. Volunteers have also addressed the stigma issues, especially with people that had been infected with COVID-19. And the community started to avoid them or have like a wrong idea about them. So the volunteer really played a key role in this. A volunteer also sensed that the people were showing more and more engagement in the COVID prevention, and they started to apply those measures with time and become more and more obeying to those things. Can we move to the next slide, please? So overall, many information were corrected during this initiative. As I mentioned, some of the false information within the community that COVID can only be transmitted by outsider, not by the same family members, but virus wouldn't survive in Libya because of its warm weather. That Libyans were already vaccinated and there is no risk on them. So really volunteer helped to provide updated, clear information, easy to be understood by the local communities. And overall, through this initiative, we have over 500 community volunteers that were trained on COVID-related topic and were deployed and helped within their own communities. And during the month of May, we have over 5,000 household visits that was done by those volunteers within the Benghazi city. So this is from my side. Thank you.
Thank you so much, Nader. Really interesting project and a lot of work. So really quite impressive from the International Federation of the Red Cross. And I apologize for getting that wrong earlier. So thank you for
actually, if I may, all the thanks go to the volunteers of Libyan Red Crescent. So Federation role was just supportive for them, providing the information with WHO and providing technical support. But the whole thank go to the National Society, the Red Cross volunteer that really did the work. Thank you.
Okay, great. Thank you for identifying them and thanking them. it's a great network and one that we all really rely on as part of our partnership. So it's nice to see the wonderful work that's being done on the ground. Thank you very much. So next we'll move on to our colleague, Sadara, but I wanted to, Samar, so I wanted to just remind everybody, if you have some questions, just after Samar's presentation, we'll go to another Q&A session. So if you have any questions for either Nadia or Samar, please again, put them in the question and answer function, Q&A function at the bottom of your screen. So with that, we'll begin with Samara Afaki from WHO. Thank you, Samar.
Thank you very much, and thank you for giving me the opportunity to participate in such interesting webinar today and hear and listen to the interesting experiences from Sierra Leone and Libya. Actually, I will talk about the community engagement in our region and what are the challenges of conducting good evaluation, and at the same time, what are the facilitators that help and facilitate documentation and the collecting evidence of community engagement in a certain situation. Next, please. Next slide, please. We have, even during COVID, we succeeded to collect many success or good practices and success stories from different countries of the region that reflect the community engagement. But we found that the most successful and sustainable community engagement example was from the cities that implementing WHO initiatives such as healthy cities, age-friendly cities, where there is already well-established multi-sectoral platform with good community representation. This is because they have, in the context of the healthy cities or age-friendly cities, community engagement is in the heart of the initiative and is a key or essential element with the community engagement and empowerment in the implementation process. There is well established, even before COVID, monitoring system, documentation and reporting system, and also evaluation process. That's why most of the success stories collected from such cities from the 15 countries that we have registered cities in our regional healthy cities network. Most of them, they rely on the volunteerism, on the community-based services, targeting the different vulnerable groups, whether socioeconomic vulnerabilities like expatriates or displaced population in the countries, or age vulnerability like elderly or adolescents or children or pregnant women, or the refugees and the nomadic population in some countries of the region. Also, the community engagement also was successfully when it with the faith organizations, because as Mr. Mohammed mentioned, they can be considered as a credible source for the communities, and also they can act as gatekeeper or entry point to any communities. So this were the different areas that was all the success stories or good practices were around them. Next, please. As I mentioned, most of the facilitators for collecting or having evidence for community engagement relied on documentation and reporting and monitoring and the evaluation in the context of other initiatives. But the challenges in our region, or based on my experience working in this area with 22 countries, it relies on the following reasons. Number one, community engagement versus engagement with the community through communication. Till now, most of the countries or the even national authorities, they consider community engagement is targeting the communities with two ways communication, convey messages and collecting their feedback. This can be true, but as Amaya mentioned in the continuum of community engagement, inform, collaborate, engage, and for sure to empower the communities to be able to play such an active role. But the communication, it stops on the informed process. So we need to go further that. So community engagement is still mixed up with communication or conveying messages. Also, the collecting evidence, it needs tools, it needs mechanisms, it needs modalities. But till now in the region, we don't have unified tools or modalities. Each stakeholder, each partner, even UN organization, they have their own tools which reflect their mandates and needs and different perspectives. But we need, and sometimes we confuse the member states by many tools like that. So we need to work on having a unified evaluation tool for community engagement. And also at the same time, such a tool will guide the countries or the communities at local levels to implement community engagement. Also, institutionalization. As Mr. Mohammed mentioned, usually the community engagement is a response to something. It's a reaction to something, but not an integrated part of the planning process, of the response process. We need to be more proactive. We need to establish and institutionalize community engagement as an integral part of policy making, or planning, or needs assessment. But at the same time, are our communities ready to play such an active role? So we need to empower them first. We need to equip them with needed knowledge and the skills to be able to play an active role, to differentiate between the actual needs and felt needs, not just to collect needs and reaction or rumors or feedback or misinformation. Also, as I mentioned, documentation and dissemination. We have, if we search on the ground, we will see many successful community engagement examples and experiences. But if we will search in the literature, we will have limited number of those documented or shared with others. So documentation is essential. We need to document the good practices to benefit the others, or even to benefit ourselves by identifying the challenges and or the problems and refine our interventions accordingly. Also, the follow-up and the monitoring. Sometimes we start something very successfully, but it will not sustain. It will not continue like it is. Volunteerism, as we heard from our colleagues previously, many successful experiences rely on the volunteerism, but monitoring and continuity or sustainability sometimes don't continue because maybe of the loss of interest, loss of guidance, and also feedback and refining. So it will reach a fatigue period, like we reached now during COVID. We call it community fatigue. Next, please. Okay, so to summarize my presentation, we have to work on the successful or facilitators for community, for collecting evidence from about community engagement from the healthy cities, because we have set of indicators that guide implementation, and at the same time it guides the evaluation and the collecting evidence, and also to work with the countries to guide them and help them to document and also sustain their efforts for community engagement in the right way. Thank you, and over to you.
Great. Thank you, Samar. Really interesting presentation. Thank you for sharing your experiences. So we have a couple questions for both you and Nader. One is from Maddie Green Armitage. So we've seen from evidence from COVID-19 community engagement that one size fits all messaging can significantly be less effective than messages that are tailored to communities. In a large scale effort, the ones that you both have experience with, how can diverse messaging and community specific initiatives be factored into your large scale community initiatives, especially if there's a headquarters support is rather limited in your work? Maybe Nadir, have you had experience with this?
I'm sorry, I didn't hear the question. Can you please repeat?
Sure. Yeah, the question has to deal with trying to ensure that you have a specific messaging for different target audiences. So we all know that having sort of one size fits all messaging isn't necessarily that effective. And we're wondering if you have experience in tailoring more specific messaging to different segments of the groups that you're working with in your community engagement efforts.
Mm-hmm.
If had success with that, and then how do you manage that when maybe you don't have a lot of support in reshaping those messages from your headquarters level?
Yeah, I think for us, what make it easy in shaping those message is having already people coming from the same background, from the same communities, really understanding what are the needs that need to be fulfilled, and they know exactly how to address it. So that really give an idea about what to focus on and what to address, and make it much easier. Because I can imagine, like even in Libya, for example, working on a community in the east is very different to working on a community in the west, where it's like 1,000 kilometer difference. So always having someone from there, we work directly with the branches in our case, that come from the same communities, the volunteer, the staff are all from that community, and really give us a vision about the need of the community and about the proper way to address their needs.
Great, thank you. Samar, do you have any other additional comments?
Thank you very much. Actually, we have the support from headquarters, but we have to adapt the messages to the regional context and then to the country's context. Because the situation will be different from region to region and from country to country. And we have our communication team here in Emru. They develop and tailor the messages based on the feedback they collect from the social platforms and online platforms, and then they pre-test. They don't, and they have to make it in the simple language. And working with 22 countries, the language different, even the colloquial language is different from country to country. So usually they tailor and adapt, and based on the feedback, they modify every now and then.
Okay, great, thank you.
Thank you.
We have another question from Christine Prue. It may have been directed towards an earlier presentation, but I think would be appropriate for you too as well. What guidance, oh man, then it disappears right off my screen. What guidance might you have to offer for doing community engagement in communities where the infrastructure is rather fractured or not quite as strong? Samar, do you have some recommendations?
Yes, I think the most appropriate guidance is to learning from experiences. Disseminating good practice for community engagement, I think this can be helpful. Also, now we are working on guidance for community engagement that can be, or framework that can guide the countries to enhance or scale up community engagement. And we have on another side to work on community empowerment, because both they are complementing each other. And as I mentioned, having evaluation tools to evaluate the efforts and the learning from experiences again, we can facilitate dissemination through our website and our Eastern Mediterranean Health Journal and all other platforms that we have. I think the guidance on the dissemination part and the how to do part.
Okay.
Thank you.
It sounds like lots of guidance and tools are available for individuals that want to take some of the things that you've learned and apply it to their own situation. Also, I just wanted to make a note that many people asked questions on how to do certain processes or how to do this, how to do that. I think some of those questions were answered in the chat room, but we will make links available to you too for those questions that need quite a lengthier answer. Also, there's some training available as well. I'm going to end with just one more question that I think that Amaya, who was our first presenter, will go back and answer. And then with that, she can lead right into our closing, where she's going to provide some observations from today's program and potential next steps for those of us working in the field, and how we can better support getting more of an evidence base around community engagement. So the question, Amaya, was, can you address the issue of community engagement being equal to the process, or is it the outcome itself? It seems that communities being involved should be a goal, ethically speaking, not just a means to an end. What do you think?
Yeah, I saw that question. I thought that was great because it's kind of philosophical in one way, but actually it's very practical in another. And I think one of the summary comments I feel too is that going sort of right back to where we started, is that very often what we do is small in scope and in aspiration, and often it's time limited, whereas the idea of community engagement is actually quite natural to many communities. It goes on all the time. So the idea of supporting communities, giving them just that little bit extra support for community engagement to be a long-term proposition, where there are platforms, if you like, or where the support is such that you're engaged with the governance structures, where you're part of decision making, the decisions that affect you in particular, where maybe you get to define exactly what your community is, whether it's geographical or something else, and where you can actually have joint accountability. Then you have actually more like a community system, which no matter what the issue is in time, you know, whether it's COVID now or it's maternal and child health later, that people are able to deal with these things long term. So I think it's partly artificial, this question, because of the way we tend to do things, time limited and very project orientated, where in fact I think that the world is definitely ready, and has been for some time, ready for, you know, a long-term support to community systems and platforms that can be there for everyday stuff that communities decide on, and also for emergencies and things like this. So yeah, I do think it's a really important question. I think it's linked to other things, like we don't tend to resource communities like we do other aspects of a response. And there are questions there about, were people paid or not paid? And that's true. Very often we expect people to just volunteer to do this kind of work, as if it's not really part of the response, and really does need to be. And increasingly, that's what we've been advocating for, to make sure that this aspect of the work is considered a formal part of the response or pillar. So yeah, I hope that's addressed it, at least in part. Thanks for that question. It's a curly one.
Thanks, Amaya. Did you want to close out with some observations for today's program and potential gaps that you identified, next steps that we can think about as a global community working in this area?
Yes, and I do think, well, that was one of my big epiphanies, was this idea of us getting behind something that can be much more long-term, and really advocating for that. Because it is a natural component and it's so important. There are also good comments about how actually we probably have better evidence around, say, community health workers, who really are community engagers. And when you think about it, they have been working in that capacity for longer, admittedly as a means to a health end, but they do receive much more long-term support as well. Whereas, as I said, often what we're doing with other issues, it's very short-term. So I think in the pursuit of evidence, because that in the world that we play in, it is important to have evidence in order to be considered part of the formal response. So I do think it is our responsibility to make sure that we are collecting the data as we go. And I think maybe it's just the type of people we are, because even in a lot of our conversation and lots of the questions, we're drawn into the doing because we know that it feels like it's the right way to work. But we weren't so much drawn into, you know, how to collect the evidence and set up the studies and, you know, the dry stuff. But even in our questions, you know, we really quickly move into the doing and how do you do this and how do you do that? And that was interesting. How did that happen? You know, so I do think there's got to be a place for that nerdy side of things where we just have to set up the systems from the start. And I did note in the chat box that we shared the links to several of the articles, but also the UNICEF's minimum quality standards. They're a really good place to start for like what is the scope of quality community engagement. And just to be a little bit nerdy, that, you know, really a lot of what we're talking about is process indicators. How do we know that we implemented what we thought we should have implemented? And then I think actually we're having less trouble with the outcome. There is a bit more of us collecting, you know, the CAP studies, the knowledge, attitudes, perceptions, you know, behaviour surveys, the quantitative and even the qualitative. We are doing more collecting of the outcomes, I think, but when we can't necessarily attribute it to the actual strategy. So I feel like we do need a bit more attention to that. And the global group has released recently a small, you know, doable set of process indicators and also a much longer list of necessary outcome indicators. So maybe we can share them as well. And just to also, I think many of the really great points that the speakers made about, you know, quality training and ongoing support and integrating community education, community engagement across the supply and demand sides, coordination and mapping, like Nedo talked about that, and that really localized and co-designing responses. The idea of scale, like being in every street, as Neda said. Yeah, I think there were just, you know, a number of like really, really great points made, including that idea of sort of multitasking, that community engagement isn't just one thing, that actually community engagement can be collecting the data, it can be interpreting the data, it can be also making plans and taking action, etc. So I'll stop there, but thank you very much. It was such an active discussion going on there. It was really brilliant. And again, sorry that we couldn't answer everything, but obviously we'll share as much as we can in terms of the background resources. Thanks, everybody. Over, Mindy.
Yeah, thanks so much, Amaya, for your observations. There were some questions about if you had questions after today's webinar, would there be a way to ask them? And there is. You can send an email to EPI-WIN at who.int. So that's EPI-WIN at who.int. Best if you put in the subject line question for the for today's webinar, the November 24th webinar. So thank you so much for joining and thank you for taking your time with us. And we hope to see you next time. Thanks. Bye-bye.